So here we're going to start talking about closing procedures. Again, we're going into our categories. There's mechanical closure devices such as coils and plugs, and then we have our uncontrolled, more liquid closing devices such as particles or liquids like onyx or gel foam. So to begin with, we're going to go into coils. These are detachable coils, which are coils that are on a long pusher wire that can be retracted, and we can choose when to detach them. So the benefit of coils like these is you can position them and see how they look before making the final decision to detach them. So they're preferred for a lot of angio cases these days. They look like a wire. They come in a house just like this, and the way that you unpackage them is often the end will be secured, and you can just pull them out just like a wire using your big long loops, long overhand loops. Coils have, if you can see very closely here, coils will have a plasticky sheath. So the orange part here is where the coil is actually inside of its sheath, and where it transitions to silver, that's the pusher wire. So the entire coil is actually inside of this orange sheath. I'm going to focus a little bit down here if possible, and I'm going to push the coil out a bit so that you can see. So you can see that this metal part is the shaft of the pusher wire, and as I push, it's actually pushing the coil out of the sheath, and the coil is not the same as the wire. You can see that it's looser, it's a noodly material. So if it were to come out of the sheath, it would be like spaghetti. So the way that we deploy the coil is it will go into the catheter. So if we focus over in this direction here, the physician will put the coil at the mouth of the catheter. This will be positioned where we want the coil to deploy inside of the patient. And what we need to do is push the noodly part, the coil, into the catheter, and then it will deploy inside of the body. So I'll show you what it looks like from the outside on the scrub table perspective. We won't actually be able to see what the coil is doing unless it's under fluoroscopy, because all of it is happening within the catheter or within the patient. So from the outside, this is what it looks like, and you'll have to look onto the fluoro screen to actually see the coil deploying inside the patient. So the radiologist will be here. They will be holding the coil at the mouth of the catheter, and your job as the scrub assist is to deploy the coil whenever instructed. Our demonstration table, once again, is not waist high, and it is also extremely short. If we were doing a full angiographic procedure, you would either need a longer length of room, or you would have to control the long length of the coil. Ideally, you would have a longer table because all IR equipment likes to be as straight as possible, so this isn't an ideal setting. I'm going to stretch the coil out, and this is going to go off of the sterile field, but in a real IR setting, you would want to have either a lot of leeway down at the end, or you would want to have some kind of management system to ensure that you're not contaminating your coil. So for our demonstration purposes, there's going to be a loop in this coil, but that should not happen. It should be straight. To deploy, you just need to feed the pusher wire into the sheath. So when the physician says, okay, deploy the coil, start feeding the pusher wire into the sheath. And what that's actually doing, if I pull this out, is inside the patient that we can't see, it's deploying the coil into the aneurysm or into the blood vessel or whatever needs to be embolized off. If on fluoro, the physician sees that the coil is in a good position, what they may ask you to do is to deploy the coil. So if that is the case, what will happen is you will need to remove this sheath completely. I'm not going to remove it because this is a piece of demo equipment that we need to use again, but all you would do is completely remove this plastic part off of the end. Then, to deploy the coil, there will be some kind of deployment device. I'm going to use a syringe to pretend, but it often looks like a little plastic wand or plastic tube that has some kind of button or switch on it. So to deploy the coil, you will insert the coil into the deployment device, whatever that might be, and then press the button or switch that causes the coil to detach from this pusher wire. And that means it is permanently inside the patient now. There is no retrieving it. That's why we always wait for the signal to deploy. Once the coil is deployed, you can remove the entire coil pusher wire. There won't be a coil on the end anymore. It will be deployed in the patient, and you can throw that in the garbage. Now, there is one advantage to a detachable coil, and that is that if there is a mistake or there is a position that you don't like, if the coil has not yet been deployed, you can undo what you have done. So in this case, let's say we have gotten to the point where we've put the coil in but not detached it, and the physician has decided, oh, I don't quite like how that looks, and I want to start again. In that case, what we would do is what's called resheathing the coil. In our example, this orange sheath might have already been removed. It might be on the side here. In that case, we just thread it on again until it looks like this once more. So our orange sheath is once again threaded on, and what we would do is hold the orange sheath in place and pull our coil pusher wire, looping it up, and the point of all of this is to sheath the coil back into its house. As you can see from down here, there is a point where we transition from the stiff pusher wire to the flexible portion of the coil. You don't want that flexible portion exposed, so resheath up until you see some kind of transition. I can see that there's black in here, and I know that it's about to go to the transition point, and I know I've pulled back enough. This is the point where I can say, oh, the coil is hubbed or the coil is resheathed, and in that case, we can just pull the whole thing out, and as you can see, it's resheathed. The coil is fully back in its housing, and it's like it never happened. We can start again. If you've resheathed a coil and you can still use it again, it's important to store it in its big loops somewhere safe on your table, and to note the measurements of the coil. For example, if this was a 60 by 45 or something like that, ruby coil, you need to write that down or remember it or note somewhere else, because if several coils are put aside and you don't remember which size is which, there are no markings on what to tell what each coil is. A second point about coils is they're extremely delicate and they're easy to detach by accident. This is a demo coil, so there are already kinks in it. But if a kink gets too bad in one of these coils, it can possibly prematurely detach the coil. So these have to be treated even more delicately than wires, which means don't do any twists or loops to store them away. Don't kink any of the wires. Don't kink the coil. If you need to store it away, you can just not coil it on itself, just store it weighed down by something. You can try and put it back in its housing if you think you can do that without damaging the coil. So once again, deploying a coil, the physician will hold the sheath at the mouth and you will feed in the coil and only detach when told. If there's been a mistake or if you want to replace the coil, it's possible to resheath it and put it away for storage.